conditions. Acute pericarditis, non-traumatic cardiac so pericardium consists of two layers, as we all know, the visceral and the parietal. Visceral will be loose, parietal will be polarized. And the space between the two layers normally will be having a 10 ml of fluid.
Edwin?
ഇല്ല 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 എനിക്കും കേൾക്കുന്നില്ല.
ഷഹീം ഓൺലൈൻ ഉണ്ടോ?
ഷഹീം
കേട്ടില്ല സാർ. ഹലോ
എഡ്വിൻ.
സ്ക്രീനും പറയുന്ന കട്ടുമാവുന്നുണ്ട്. എന്റെ ആണോ എനിക്കറിയില്ല.
സ്ക്രീൻ ജസ്റ്റ് കണ്ടു.
ഇപ്പഴാ കണ്ടു. ശരി ശരി.
എവിടെന്നാ സാർ മിസ്സായത് സാർ? അക്യൂട്ട് പെരിക്കാർഡൈറ്റിസ്
കുറച്ച് നീ അവിടുന്ന് പറഞ്ഞു. അക്യൂട്ട് പെരിക്കാർഡൈറ്റിസ്.
Topic is acute pericarditis. The causes: the infection, viral infection, bacterial, fungal, and the malignancy can lead to acute pericarditis, such as leukemia, lymphoma, drug-induced, procainamide, hydralazines, and rheumatic disease, especially rheumatic arthritis, can end up in acute pericarditis and radiation-induced and post-MI. It's known as Dressler syndrome, and conditions like uremia, myxedema, and idiopathic. Now, what are the features? The symptoms, the character would be sharp, stabbing pain, and the location would be precordial or a retrosternal chest pain. And onset could be either sudden or gradual onset. And there could be radiation to back, neck, left shoulder, or arm, and also referred pain to left trapezoidal edge, which is a distinguishing feature. The pain could be aggravated over movements or during inspiration and relieved by sitting and leaning forward. The associated features could be fever and dysphagia. Now, what are the signs? The most important finding is the pericardial frictional rub, which is auscultated in the lower sternal border or apex when patient is sitting and leaning forward. And the pericardial rub is said to be having often triphasic, which is having a systolic component, an early diastolic component, and a pre-systolic component. Now, how will make a diagnosis? Now, coming to the ECG, if a large pericardial effusion develops along with acute pericarditis, then you can see low voltage complex and epical wall trends, the pendulum motion of heart with fluid filled pericardial space. ECG changes seen in acute pericarditis, which is the ST-T wave changes, may mimic that normal variant with early repolarization. So it is very important to distinguish or differentiate between an acute pericarditis and of a patient with a normal variant of early repolarization. Now, ST-TB ratio leads V5, V6, and lead 1 is calculated to differentiate these two conditions. Now, using the end of PR as the baseline, the amplitude of the ST segment is noted in millivolts. Similarly, the height of T wave from baseline is calculated in millivolts from above mentioned leads. V5 is a lead ratio. We are calculating that two amplitude ratio calculated, and it's more than 0.25, more likely to pericarditis, and it's less than 0.25, it has more of a chance to be the normal variant with early repolarization. So this ratio of ST-T wave ratio in the leads V5, V6, and lead 1 is calculated, and the ratio, if it's more than 2.25, it's more chance to be pericarditis. The radiographic assessment is not much helpful in diagnosis. If all chest X-rays are available, we can compare for an increase in cardiac load. Other important is to identify any underlying cause leading to the pericarditis, such as the different causes as well as neoplasm infection. Epicardial fat pad sign rarely seen. Now, what is epicardial fat pad sign? That we'll discuss in the coming slide. Echography is the procedure of choice for detection, confirmation, and serial follow-up of acute pericarditis and pericardial effusion. A separation is seen between right ventricle and chest wall and between left ventricle and posterior pericardium. And sensitivity of CT to detect pericardial effusion is similar to that of echocardiography. This is a procedure of choice for detection. Now, in this figure, we can see the fluid being seen between the left ventricle and the posterior pericardium. And there's a posterior effusion and there's an anterior effusion in the first picture. And as you can see, effusion is also the second view. Now coming to ancillary testing, which is the further testings which we order, like cardiac markers such as CKMP and troponin may be elevated due to associated myocarditis. All the routine blood counts, the urine serum creatinine for uremia, uremic pericarditis, streptococcus, serology, viral antibodies, all will detect if there is an infection for acute pericarditis. Now, treatment and disposition. The most patients with idiopathic assumed viral pericarditis will be having benign course lasting for 1 to 2 weeks. So symptoms respond well to NSAID as ibuprofen, doses 300 to 800 milligram over every 6 to 8 hours. And colchicine 0.5 milligram orally twice a day can be used as adjuvant and may prevent recurrent episodes. The admission and echocardiography indicate symptoms don't resolve and new symptoms occurs or the already symptoms worsens. So this is how we treat.
Edwin കട്ടായി പോയോ പിന്നെ?
അതെ കട്ടായി
കട്ടായില്ല. സബ് കേൾക്കാവോ?
ഓ കേൾക്കാം കാണുന്നില്ല പക്ഷെ
ലോഡിങ്. ഈ സ്ലൈഡ് കണ്ടാണോ സർ? പിന്നെ ഡിസ്പോസിഷൻ. ഹലോ,
ഇതിന് മുമ്പത്തെ സ്ലൈഡ് എടുത്തോ.
കണ്ടാണോ? റിപ്പീറ്റ്
ചെയ്തോ.
Okay. So echocardiography is the procedure of choice for, and we have seen that CT will be showing a change. We have to differentiate between early and normal variant with early repolarization. But the procedure of choice to detect the acute pericarditis is echocardiography. As we all need to, there will be separation seen between right ventricle and chest wall and between left ventricle and posterior pericardium. And sensitivity to CT to detect pericardial effusion similar to that of echocardiography. So we have seen the effusion, the anterior effusion, posterior effusion in the first view, and second view we can see the effusion. So that is a procedure of choice. The ancillary testing mainly concentrates on whether the patient is having infectious causes. For that, we send the routine blood counts and blood culture, streptococcus serology, viral antibodies, and urine serum creatinine will give us an idea whether the patient is having a uremic features and leading to uremic pericarditis. And the cardiac markers may be elevated in associated with myocarditis. Now, treatment disposition, the patients with idiopathic presumed viral pericarditis will be having a benign course lasting for 1 to 2 weeks, and symptoms will respond well to NSAIDs such as ibuprofen. And colchicine 0.5 milligram orally twice a day can be used as an adjuvant. And admission echocardiography is indicated if the symptoms worsens of the new it does not relieve. So if these symptoms are not relieving, or if it's worsening, we have to advise admission and further echocardiography and management. The indicators of poor prognosis: if temperature more than 38 degrees Celsius, subacute onset for weeks, immunosuppression in the patient, history of oral anticoagulant use, associated myocarditis, large pericardial effusion. So all these may indicate admission for the investigation, including echocardiography. And that's about the acute pericarditis. Now coming to the second condition, which is non-traumatic cardiac tamponade. Now in the figure, as you can see, the compression of the heart due to fluid accumulation within the pericardium. That is the pathophysiology. The pathophysiology, if there is an increase in pericardial fluid, we know, normally there's a 10 to 15 ml of fluid in the pericardial sac, and if there is an increase, there will be an increase in the intrapericardial pressure. So at first, the large increase in the volume will only cause small rise in the intrapericardial pressure, but pressure increases substantially when the parietal pericardium reaches limits of distensibility. So increased intrapericardial pressure will be more than that of a normal filling pressure of the right heart chamber, and that will lead to restriction of the filling of the ventricles, which is leading to the condition, as we all know, called cardiac tamponade. The common causes of the metastatic malignancy, acute idiopathic pericarditis, uremia, bacterial tubercular pericarditis, and hemorrhage. The clinical features, some symptoms, most of the time it will be non-specific. The common complaint is dyspnea at rest or on exertion. Additional symptoms due to underlying condition, uremic features may be presenting, but tubercular pericarditis. All those associated features may be present depending upon the causes. Examination findings: the patient will be having tachycardia, low systolic arterial blood pressure with narrow pulse pressure. Pulsus paradox may be present, but it's not a diagnostic tool. Neck veins may be distended. The heart sounds will be soft. The right upper quadrant tenderness due to hepatic venous congestion. Then diagnosis: the X-ray may be showing a large cardiac silhouette with epicardial fat pad sign, and the ECG may be showing low voltage QRS complex, ST segment elevation, and PR segment depression, and electrical alterance, which is a classic sign, which is due to the pendular motion of the heart in the pericardial fluid. Now, this is the epicardial fat pad sign. In this figure, this is a lateral chest X-ray of the patient with cardiac tamponade or pericardial effusion. You can see a two translucent line denoted by the blue mark and the yellow mark, and in between the two translucent line, we can see a opaque line. That's denoted by the star, yellow star. So that shows that's the epicardial fat pad sign denoting the pericardial effusion. The diagnosis must be suspected based on the clinical assessment of chest X-ray, but the diagnostic test of choice is the echocardiography. The echo findings will be right atrial compression, right ventricular diastolic collapse, abnormal respiratory variation in the tricuspid and mitral flow velocities, and dilated inferior vena cava with lack of inspiratory collapse. The treatment and disposition in these cases will be immediate volume expansion with a bolus of normal saline solution, will increase intravascular volume and facilitate right heart filling and cardiac output. This is a temporary step. But the definitive treatment is the pericardiocentesis. Now, if the patient is in hemodynamic instability, the emergency pericardiocentesis is required to be done in AD itself. Otherwise, it is preferred to be done in cath lab after taking the cardiology consultation. So that's about the non-traumatic cardiac tamponade. Now, coming to the constrictive pericarditis, now as in the figure, we can see that it is due to the inflammation of the pericardium. It results from pericardial injury or inflammation, which lead to the fibrous thickening of the layers of pericardium, and this will prevent passive diastolic filling of the cardiac chambers, leading again to the cardiac tamponade effect. The causes are the post-cardiac trauma following intrapericardial hemorrhage after pericardiotomy in the open heart surgery, or the fungal or tubercular pericarditis or chronic renal failure, again uremic pericarditis. The clinical features usually occurs late and it often mimics that of chronic heart failure and restricted cardiomyopathy. The symptoms occur early if there is a fluid accumulation in the fibrous layers, which is known as effusive constrictive pericarditis. The common signs and symptoms consist of exertion dyspnea, hepatomegaly, and ascites. Jugular venous pressure is very commonly found with a very rapid wide descent of the cervical venous pressure. The cosmal signs, inspiration, neck vein distension is also very frequently found. And on auscultation, we can hear pericardial knock, which is heard after second heart sound at the apex. Now, the knock is due to accelerated RV inflow in early diastole and early myocardial distension, followed by an abrupt slowing of further ventricular expansion. That's about the pericardial knock. The diagnosis, again, the ECG will be showing a low voltage QRS complex and T waves are common, but no specific ECG findings. Radiographic assessment will be showing either normal or slightly enlarged cardiac slope, clear lung fields, and pericardial calcification can be seen. And echo shows pericardial thickening and abnormal ventricular septal motion. But a definitive diagnosis is by cardiac catheterization. Now, this is to determine the intraventricular pressures to confirm the diagnosis, and a dip and a plateau sign, which is known as square root sign of the right ventricular pressure, is diagnostic. And you see in the figure, there is a square root sign, which is a dip and a plateau sign. It's very, very typical or the diagnostic thing for the pericarditis. And pericardiectomy is the treatment of choice in this in these cases. So that's about the three conditions of pericardial disease. Thank you.
Okay, Edwin, that was a beautifully covered presentation. You've mentioned what's only to be mentioned. Like we've discussed, we've heard acute pericarditis, pericardial effusion, and cardiac tamponade. All these things are usually something that we tend to look over in the ED. So whenever a patient comes with chest pain, we are thinking only of ACS. But again, once everything has been ruled out, you have to also think in terms of pericarditis if your history and clinical examination is tallying a lot. But one thing I would like to mention in Edwin's presentation. Edwin, when you read this topic, did you find any stages of pericarditis? Stage 1, stage 2, stage 3, stage 4?
ECG changes also. ECG.
Are there?
Sir.
Okay, so basically, ECG the most common something that you might first look will be a STEMI. So sometimes you might look, you will find ST elevation mostly in all the leads. So when you find an ST elevation in all the leads and not concordant leads, that is one of the mimickers of STEMI. It's a differential diagnosis for STEMI. So on that note, can I ask you, Edwin, what are the differential diagnoses for STEMI?
ECG changes are only a presentation based on.
Presentation based. If you see a STEMI patient, if you see ST elevation in most of the leads or in some leads, what are your differential diagnoses? One is MI, next is
pericarditis.
Okay, one is pericarditis. One is pericarditis. You can have ST elevation. Then tell me 4 causes. Actually, there are 12 causes. 12 causes in the STEMI mimickers. At least 4 causes. Anybody?
Brugada syndrome.
Brugada, very good. Any electrolyte abnormalities?
Hyperkalemia.
Hyperkalemia, you can have, not always, you can have ST elevation. But adinde ST elevation would not look like a classical MI ST elevation, but you will definitely have elevating STs when the range comes to around 7 to 8. Okay, so whenever the investigations that is available to us in the ED are only practically a ECG and a chest X-ray. ECG findings could Sami, can you tell us the ECG findings in pericarditis? Most classical.
There will be pan ST elevation.
Pan ST elevation. So ST elevation will be there in all leads, unlike an MI where you have only concordant lead, single inferior wall, lateral wall with reciprocal changes. In pericarditis, you will have ST elevation with reciprocal changes in AVR. So you will have, if you have ST elevation or ST going up in all your leads with PR segment depression. So in the acute phase, you will have PR segment depression. So for your spotters, if you have an ECG put for you with ST elevation in all the leads with or a PR depression, then you have to the first thing it's going to be pericarditis. So whenever you see such a feature, you have to look at AVR also. When you look at AVR, you will have reciprocal change. You will have ST segment will show depression and PR will show elevation. So that is how you differentiate an MI from pericarditis. Where as time goes by, what happens to all these changes, Sami?
So there will be de-inversions,
Okay,
flattening and de-inversion.
correct. So as time goes by, like around when it goes more than 3 weeks or say around 1 to 2 weeks to 10, you will have the ST segment will come back to the normal, PR segment will come back to normal. Then you will see only T wave problems, right? Either T wave flattening or T wave inversions. So it is during the first acute phase, in the 1 to 3 weeks, our phase like ECG changes. So that's about the ECG in pericarditis. Now, what are the echo findings in pericarditis, Edwin? What can it range from? Oh, one more thing. Sorry, one more thing. Like Edwin said, on the ECG, you're going to look at electrical alternance. I hope electrical alternance is also a spotter question. I hope why electrical alternance happens, you all know. Edwin has mentioned it. Why is it, Edwin?
Pendular motion of the heart within the pericardial.
So the heart is swinging in the pericardium in a bubble of fluid. Okay. So that's about the ECG. Then what do we have to go to? We have to go to the echo. Okay. So Edwin, can you just briefly describe what you're going to see on the echo?
In pericarditis, if there's a formation of pericardial effusion in the long axis, we can see either anterior effusion and the posterior effusion, which is a opaque area between the left ventricle and the pericardium.
Okay. How do you differentiate a pericardial effusion from a pleural effusion on an echo, on a plaques view, in the first view?
Pleural effusion, diaphragm.
Pleural effusion. When you look at the plaques view, the parasternal long axis view, that is the first view when you do your point of care echo, how do you differentiate between a pleural effusion and a pericardial effusion? The easiest answer is I will take the probe and put it in the behind the chest and look at the pleura. Okay. But in the plaques view, how will you differentiate? Okay. So any other findings on the echo that you want to tell everybody about? In effusion, it can range from a normal small effusion to a tamponade. Okay, so I'll just share one screen. Okay, I hope you can see this. This is just my presentation which I did for Asta. So this is effusion. Okay, I hope you can see the fluid in the pericardial cavity. So what can you see here? So this is the plaques view. The figure A is the plaques view, and the subcostal view, not the plaques view, the subcostal view. And what can you see in this? You can see a hypoechoic fluid all around the pericardium. So when you see such a fluid, what's going to happen? This is something that you're going to see. The heart is going to dance in this bag of fluid. So when you see this this thing, 1 minute, just a minute. Okay, so when you see this, I want you to appreciate one thing here. We have the RA, we have the RV, you have the LA, and you have the LV. So look at how the RV is getting, sorry, I'll just switch that way. Yeah, look how the RV is getting collapsed. So this is something that you should be quite scared of, okay? When you see an RV like this that is collapsing into the lumen of the RV. Now, whenever you see pericardial effusion, like Edwin said, okay, epicardial pad fat sign is usually seen on the lateral X-ray. We don't usually take a lateral X-ray in practical, but this is for when you know about the topic, you have to know that small amount of pericardial fluid can be picked up on a lateral thoracic film X-ray. So whenever you see a a hypoechoic fluid here, you see a hypoechoic fluid here, you always see for the thoracic aorta in the plaques view. This is the first view. I hope you can appreciate that. You always look for the thoracic aorta. If the fluid passes through the thoracic aorta like this, that means that it is a pleural fluid. If it does not pass, if it stands up to, if it ends at the beginning of the thoracic aorta or at this point, that is only a pericardial fluid. So that is how you differentiate a pericardial and a pleural. Pleural will go beyond the aorta, the thoracic aorta, and pericardial will not go beyond the thoracic aorta. Sometimes it might not be very easy to make it out in this view, plaques view. Next, whenever you see fluid in your pericardium, you have to check for the size of the fluid. Okay, you have to check whether there is small amount of fluid in the pericardial cavity, whether it is moderate amount or large amount. So for that, what you have to do is you have to measure the distance between the heart chamber and the end of the pericardium at the end of diastole. So at the end of diastole, you're going to make this measurement. And once you make this measurement, you see whether it is with less than 1 centimeter or 1 to 2 centimeter, more than 2 centimeter. So if it is more than, so that is how you will have to communicate to your cardiologist when you do your echo. If they ask you, what is the size? Is it a small, moderate or large effusion? This is what you have to, this is how you're going to tell them that it's a small, moderate or a large effusion. These are the logistics. Less than 1 centimeter, moderate is 1 to 2 centimeter, and large is more than 2 centimeter. So, and the last spectrum of this whole thing is a tamponade. So what is, how do you clinically say that a patient is in tamponade, Edwin?
The pulsus paradox, maybe. So.
Okay, pulsus paradoxes in a busy ED is going to be very, very, very difficult to find out. Okay, hypotension. What is cardiac tamponade? Hypotension. Shaim, what is the triad associated with it? Sami? Beck's triad. So Sami, could you tell them what Beck's triad is all about? Beck's, B-E-C-S, Beck's triad. Okay.
Hypotension, extended neck veins, and muffled heart sounds.
Muffled heart sounds. So this is the classical triad of cardiac tamponade. Is someone speaking? Okay.
Background sound.
Okay, so my point being, whenever you see fluid in the pericardial space, the next thing that you have to think is my patient in tamponade? Now, clinically tamponade, you can call it tamponade clinically only if you have hypotension. Hypotension, probably if tamponade is the reason for hypotension, definitely you're going to have distended neck veins and muffled heart sound. So that is known as the Beck's triad. But sometimes even before the patient develops hypotension, with our echo, we can say that our patient is prone for a hypotension, or the BP is going to fall in this patient soon. So how are you going to make a diagnosis of tamponade on the echo? That is what the cardiologist wants. If you have a patient who's come with a massive pericardial effusion, with a BP of say 120/80, you are safe. You can say that clinically this patient does not have tamponade. But you have to take your echo. Once you take your echo, just a minute. Once you take your echo, you are going to see this view. So what happens when fluid increases in the pericardial space? Once it reaches, like Edwin said, once the pressure in the pericardial sac is more than the intracardiac pressure, what's going to happen is your RV wall, that is the RA and the RV free wall, is going to collapse because now there is more pressure in the pericardial cavity. So when you have that collapse, you're going to see like something like this. Okay, you see the RV, you see the RV, you see the RA, and you see the RV. So you see this collapse like this, right? Something has gone inside. So if you see this collapse at the end of diastole, that means that your patient is having tamponade by echo. So you have to look for right ventricular end diastolic collapse. So I hope that is clear. Is it clear for all you three? Shahim, Edwin, and Sami? Sami kya rahe hain? Is it clear or should I repeat it again?
Okay.
Edwin?
Yes.
Is it clear?
Yes, ma'am. Yes.
Yes. So basically, you're going to look on when you see pericardial effusion, you're going to look for RV end diastolic collapse. Now, I'll tell you what's going to happen is, imagine one man is standing at this particular space. Okay, like imagine a man is standing here and he's going to start jumping on the RV. So that is how you will feel when you have a tamponade by effusion. So that is the findings on the echo. Something ahead that once we find out pericardial effusion, you have to look for tamponade. Okay, so what else should we discuss about? So we talked about the echo findings. Again, if you how are you going to investigate a patient with pericardial effusion? What are the most common causes that you usually see? Somebody, Edwin?
Infections.
Infection. So viral infections, but more than infections, usually malignancy. Malignancy is one of the most common causes for presentation. So suddenly patient might come with chest pain, with breathlessness, and then only when sometimes you might auscultate, you might not be able to appreciate anything in the BCD. So you have to, when you put your echo probe only, you will find out that this is an effusion. So sometimes effusions might be the first point to find out whether the patient is having a malignancy. But some workup that has to be given in the ED is basically your rheumatological workup, your thyroid workup, apart from your normal routines. Okay, that's all. Rheumatological, you can send your ANA. Thyroid, you can send your TSH. Also, something I hope you know that in volume overload patients, like for example, CKD patients, they might have uremia. Like when you have chronic uremia, long-standing uremia, it's going to cause uremic pericarditis. So my question is to Sami, when you have a patient, a dialysis patient, or in your acute care too, who's undergoing dialysis, and this patient has got pericardial effusion, or this patient is having pericarditis, what are the extra things you will monitor in such a patient with respect to dialysis? Sami? Hello? Welcome. Okay. Sami, okay. So whenever you have a patient on dialysis, if you have a patient with uremic pericarditis and you are sending this patient for an HD, in the hospital maybe we don't have to bother about all that. But whenever you have a patient with uremic pericarditis and you're going to send that patient for HD, you should always think twice while using anticoagulation in the ED. Okay, during the HD, because they usually give heparin and all that. But if the patient is having a massive pleural effusion, massive pericardial effusion, never use anticoagulation, because that can lead to a hemorrhagic pericardial effusion, and that is going to complicate your problem. So you should, and probably if a patient is on having uremic pericarditis or uremic pericardial effusion, the frequency of HDs might be more. First of all, uremic pericarditis itself is an indication to do HD.
Indication for
HD, yeah, that is the first point. Paksha, if whenever you have such a patient, always be cautious on using anticoagulation, because this can get transferred into a hemorrhagic pericardial effusion anytime. Okay. Baki colchicine, ibuprofen, and all that all that I have. That's the same knowledge that I have, what you have. But these are the things that I would like to stress when you deal with a patient with pericarditis, when you deal with a patient with pericardial effusion, and when you deal with a patient with tamponade. So always understand the physiology of cardiac tamponade whenever you deal with patients. Always start BiPAP only if it is necessary. Please be careful of volume or overload in such patients. Give your volume judiciously. So it is just like if you're planning to do if you have such a sick patient that is going to collapse in front of you, or a pericardial effusion which is so unstable, then a patient that cannot be shifted to the cath lab, then only you go and do your pericardiocentesis. Or if you have a patient who's arrested in front of you. But whenever possible, it has to be done under fluoroscopy or under imaging guidance. So probably I have a class on pericardiocentesis. We'll talk about the physiology and the steps there. Okay. So I hope today's class is done. Anything else? Anybody would like to recall or re-stress on any topic? Anybody? Always don't forget to send your cardiac enzymes to rule out myocarditis, and obviously look for signs of failure also. When you have all that you will definitely get on a complete echo. Okay. And anybody has any doubt regarding today's class? The echo finding, anything? Okay. So I hope it's clear. Venu sir and Venu sir. Venu sir.
Abraham, it's perfect. Everything is covered.
Okay, sir, thank you.
Explain perfect. It's good. Very
Okay,
good.
sir. Okay, so thank you. Just to wind up, I'll tell Sami and the PG students here that along with this, on a higher note, there are two things that get yourself familiarized with. One is called ventricular interdependence. Ventricular interdependence and the phasic variation in the hepatic veins. So just like how there is something called VEXUS, VEXUS, V for van. So VEXUS is something that is coming new into the system to guide fluids whenever by looking at the renal parameters, the liver parameters and all that. So just go back and read about ventricular interdependence in tamponade physiology, and also the phasic variation or a D wave diastole and down in hepatic vein morphology when you put your pulse wave Doppler. These are the two things that you have to read extra about. Otherwise, baki ellam basics are what we usually do in the ED. Okay. Okay, sir. Venu sir, thank you.
Okay.
Thank you, guys. Thank you, guys.